Greetings and welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA.
So, good morning. Today, I'm going to talk to Onima Chowdhury. She is a hematologist from the University Hospital in Oxford, and she works both with the clinics and in research. So, a very warm welcome to you, Oni. We're going to talk a little bit about the diagnostic workup of MDS and what's needed and maybe what we don't need and how we can do this best in different situations. So maybe you could just start by explaining us what you normally do, or what do you think it's important? Yeah.
Yeah, sure. So I guess thanks very much for inviting me. And the basics are reasonably sort of well established and straightforward. So to diagnose myelodysplastic syndromes, you need cytopenias. So obviously a full blood count is absolutely essential. And then following on from that, morphology is really the mainstay of diagnosing myelodysplastic syndrome. So typically that would be with a bone marrow biopsy, but full blood count and a film can also be very helpful. So normally a blood count and then bone marrow cytomorphology would be the real basics. And then moving on from that, there are more detailed diagnostic tests that are required.
I think I would like to talk a little bit about the morphology of MDS, because I think that's actually, according to what I as a clinician see, I sometimes think it's very variable how this is described. I mean, particularly in low risk MDS, right?
I think that's really true. And there are numerous sort of international studies that have been published saying that there's a lot of inter-observer variability in terms of what I would call dysplasia and what someone else would call dysplasia. So like you say, in the lower risk patients, it's a much bigger deal. If you've got, barn door blasts, really crazy sort of red cell morphology, it's a lot more obvious, no clear other reactive possible cause. But obviously in the majority of our patients, that's not the case. It's an older person who's gone to their practitioner for a tiredness. It could be a number of things in the background, mildly low blood counts, a blood film that is potentially a little bit abnormal, and typically we're supposed to say more than 10% of the cells in a particular lineage are dysplastic.
Yeah, so just to emphasize on that, so it's any lineage right now. I mean, it doesn't have to be several lineages, just any lineage that's dysplastic.
Yes, exactly. And ideally more than 10% of the cells. And again, the WHO suggests that you look at 500 cells, ideally. I mean, on a regular day, if I was looking at a number of marrows, that's probably not the case for most people. I think we'd all admit that. I think 200 is probably what most people would be looking at.
So if we go on from morphology, what's the next you would do?
Yeah, so I think everyone really would try and get a trephine biopsy, which can be very helpful in terms of not just the architecture, but also the cellularity is much more reliable on a trephine. And also looking for additional features like fibrosis can be helpful if you're thinking about an MDS or an MPN overlap. That's often really useful, I think, to have a trephine.
And fibrosis is also important for prognostication, isn't it?
Yes, exactly. So your prognosis is not so good if you have fibrosis, so that's very, very important. And also just looking for additional features that may indicate there's a mast cell disorder, that has the dysplasia associated with it or something along those lines. So I think a trephine certainly at diagnosis, not necessarily, we might talk about following up each time you might do a marrow, but at baseline, a trephine is very helpful. And then I guess you move on to cytogenetics. So typically a karyotype would be of 20 cells, and we would always request. Sometimes that fails, which again we can talk about, but ideally you'd be looking at 20 metaphase chromosomes to look for.
And this is simply because the cells will not grow in the dish, or?
Yeah, exactly. And if we've got a poor quality sample, there's been any delay, if you're not looking at them locally but sending them away, it can be problematic. But yeah, so that's and only 50% of patients with myelodysplastic syndromes, or neoplasms as we now call them, have a karyotypic abnormality. But so that's really important. And we also, I guess this varies probably from practice to practice. We would always do a panel of FISH probes, so fluorescence in situ hybridization probes, particularly if the karyotype has failed, looking for things that are very typical of MDS, so chromosome 5, 7, 8, or P53 related abnormalities.
So you do that routinely, or you only do it if your cytogenetics fail?
We typically only do it if our cytogenetics fail, or if there's a specific speed is often another reason to do it. So the FISH will come back a lot more quickly than your karyotype will do in most settings. And in some cases, we would also do a SNP array. If we have a failed karyotype, we're really worried, looking for a clonal marker. So that's a more widespread look at the chromosome level for any abnormalities that we might pick up. But that may not be available, I think, to a lot of clinicians.
No, I think you're right. That is probably not what people usually do. So in order to look for this dysplasia, do you use any tools? Is there anything that can do online or AI?
So whatever? We don't usually use it, but there are definitely, certainly in the research sphere and coming forward towards the clinic, there's a lot of interest in using artificial intelligence in all its sort of guises. So I mean, I always view it that certain things, you really need an expert clinician for sort of the nuanced diagnoses, things where it's, there are unusual features. But actually, we know that computers are much better at picking up patterns than we are, and the reliability and the reproducibility. So things where we know there's a lot of inter-observer variability, so morphology, whether it be aspirates or trafines, flow cytometry is another one, where actually you can use the machine learning. There's a lot of capacity for improving on diagnostics and improving throughput in labs. So actually we can get more patients diagnosed more effectively. And I think that's definitely something that we're looking at in terms of a research angle. And there are numerous publications and things are presented always at conferences in terms of how this could really transform diagnostics.
But it's still quite far from the clinical use.
Yeah, I think it probably is in terms of validating these things within a clinical trial setting. But I think that's definitely the way that we should be going. So we can focus more on the sort of nuanced diagnostics rather than the stuff that clearly computers are better at than me. Yeah.
Which is actually very nice, because it also means that maybe more labs can come up with the right diagnosis, because often these patients end up somewhere else, right? At least in the beginning, right? So
completely. So I guess systems vary in different places, but certainly in the UK, all hematopathology comes to certain centralized centers. But that's only probably within the last, 10 years or so. So that because hematopathology is a real skill.
Yeah, it is.
Really encouraged.
It's not easy.
No, it's not easy. And it is different, I think, to solid organ pathology. So I think, again, having that centralized system works, but being able to do a lot of things locally would obviously help throughput as well. And machine learning, I think, can really help with that.
Yeah, good. And what you mentioned flow cytometry. Is this necessary, and what extra do we get out of flow cytometry?
Yeah, so I guess for me, with my interest in myelodysplastic syndromes, I'm always trying to think about how we can incorporate it into our flow lab, but it's not required. I think that's the bottom line at the moment in terms of for diagnostics. It's not required to diagnose MDS. But there are, again, numerous publications that there's scores that have been produced, for example, the Agata score, or other scores where you can use essentially ratios of different progenitor populations, be they myeloid or lymphoid. So simple parameters. I think scores are always better if there are fewer inputs that you can use to sort of say it is more likely that this person will have MDS versus a reactive cause for their dysplasia. And I guess the advantage of flow is that it's quick. Again, you can hopefully get a result within 24, 48 hours. You're looking at live cells. You're looking at all of the cells rather than already selecting off a population. So I think there is a place for it, but probably not necessary in terms of routine diagnostics. The other place that's clearly growing is in terms of looking at sort of the immune landscape within.
Yeah, exactly. Because that was what I was thinking. We always talk talking about how important the immune system is for the development of MDS, and we sort of ignore this in a way. I mean, this is not normally the things that we get out. So how do you envision in the future that this may be?
I mean, again, it's really important, isn't it? Because I mean, 25 to 30% of patients with MDS have an inflammatory or autoimmune condition, and this has been recognised for some time. But I think it's becoming, people are thinking more clearly that are these linked, and so that's important from a clinical perspective. And then thinking about how some of the treatments that we already have work. You know, the only curative treatment is a bone marrow transplant, which is effectively, you know, the ultimate immunotherapy. Patients with lower risk MDS or hypoplastic MDS that are treated a bit more like aplastic anemia have had cyclosporin, ATG treatments like that clearly affect the immune system. Azacitidine clearly has an impact on the immune system. So there are lots of reasons to think that the immune system is important, and it clearly is. And so actually having a panel that can incorporate immune markers as well as sort of blast markers will be very helpful. And as you know, there's a big effort to get this going with the I4MDS consortium.
Exactly, that's why I was trying to get that. Because the EHA is sincerely involved in that, as you know.
Yeah, exactly. So that and that makes a lot of sense. But I think the problem with flow, a bit like you've said with morphology, is there is a relatively subjective element to it. I'm a big flow cytometry fan. I've done loads of it, and I lead the flow cytometry service in our diagnostics lab. But you need to overcome that in terms of making sure that people are using the same markers. It's validated on big cohorts, because it's not always just sort of presence or absence. There is a more nuance to it. So I think having what you need is a big sort of international working group working to get together for a clear panel of markers that have clear clinical utility that a scientist in a standard flow lab would be able to work with.
Yeah, I think also this is one of the aims actually of the IPM.
Yeah.
So moving on a little bit, what about the role of NGS in the diagnostic setting? How important is it?
So it's becoming increasingly important, I think, and for a variety of reasons. So I guess, well, it's a number of years now since we first realised, over 10 years, that there are the recurrently mutated genes in patients with myelodysplastic syndromes. And unlike sort of the lucky people who look after MPNs, they're not as clearly defined as they are with the myeloproliferative neoplasms. But we have a collection of mutations that are clearly important in terms of identifying a clonal disorder. But not only that, they can help with diagnosis. So in some settings, with things like P53 or SF3B1 would be the sort of the clear examples where they have a clear prognostic and diagnostic relevance. And now, with the publication of the IPSS molecular score, we have data now, or the paper was published last year on 3,000 patients, predominantly Europe, US, and Japan, but relatively international, showing that you can incorporate mutations, 31 mutations in the paper, and full blood count data and cytogenetic data, and be able to stratify patients more clearly using this new score, which essentially over time will be incorporated into clinical trials and is being incorporated into sort of routine practice for us to be able to more accurately prognosticate on our patients. So it's not really about necessarily diagnosing them. These were all patients in the paper that were being diagnosed with MDS, but actually thinking about how you can offer a more accurate prognosis and how that might impact on treatment and clinical trial cohorts. I think it's clearly making a huge difference, and not just in big labs that have been used to doing it for years.
I really agree on that. I really think it helps a lot. But and I think maybe we should mention here also that you can actually use it even though you don't have all the genes, right? All the genes included in your panel. But something that's very critical in this is actually TP53 biallelic or monoallelic. I mean, do you manage to get that out of your panel?
Yeah, so no, is the honest answer.
No, exactly. That's what I think. It's a very important thing, right? So.
Again, it's sort of you have various criteria that have been proposed in terms of how you might. So the importance of this is obviously that, again, published a few years ago, I think 2020, that we all thought previously that anyone with a P53 mutation was going to be absolutely dismal prognosis. But what's come out of the work really is that about 2/3 of patients have a multi-hit P53 mutation, specifically with MDS, which means that they've got either 2 mutations, they might have 1 mutation and then loss of 17p, or 1 mutation and a copy neutral loss of heterozygosity on the other chromosome. And so that would make it a multi-hit event. Whereas if you have a single hit event, so just 1 mutation in a number of different mutations, sometimes I think it's not clear to other people that it's not a specific mutation, just 1 P53 mutation, that your prognosis in a number of studies now has been shown to be nowhere near as poor as if you have a multi-hit P53 mutation. But the problem in a diagnostics lab is you're looking at bulk DNA. So you're effectively taking your granular sites, you're extracting all your DNA and then sort of putting it all together and coming up with a mutation. So I think if you've got 2 mutations that have got ideally often similar VAFs, then you've got likely double hit. If you've got a P53 mutation, your karyotype comes back and they've got loss of 17p.
Then of course,
double hit. The problems arrive when you start trying to sort of derive cutoffs of variant allele frequencies. And we also know, talking a bit about research, that if you look at single cell data, that it's not always brilliant. So that if you think, you've got a P53 mutation of 20% or 20, 30%, or they'll have a multi-hit mutation. They don't always have a multi-hit mutation when you look at single cell data. So it's not always clear cut. So we do need to be able to improve on that. But broadly, for a clinician wondering whether their patient does have a poor prognosis P53 mutation, which is what it comes down to, I think in most patients in a clinical setting, you can unpick that from a combination of diagnostic
analysis. Yes, that's true.
Not just from the NGS. The problem arises when you've got those sort of intermediate variant allele frequencies in a patient who's quite well, and then what am I going to tell them? Like, is this?
Yeah, exactly.
Or actually you're going to be one of those ones that does just bob along for ages, because we definitely see those P53 mutations in various myeloid malignancies where actually they just have a relatively low level of mutation for a very long time, and it doesn't have any problems.
And also I think there it's a challenge, because when you discuss with the transplanters, right, it's not really something that they look into whether there are P53 mutations, right, or not, right? So, okay, to move to another end of the spectrum, what about when you have this patient that comes from the GP with a long-lasting cytopenia? How important is the NGS then?
So if the patient's been an older person with a long-lasting cytopenia, with no other obvious cause, I guess is what we're saying. So the GP has been through all the other sort of routine bits. So we kind of use an NGS panel in 2 different ways. So if we think there's no way we're going to really want to do a bone marrow biopsy in this patient for whatever reason, other practical reasons, comorbidities, they're extremely frail. On the one hand, some of my colleagues argue, well, what's the point in doing a peripheral blood NGS panel? You're not really going to do very much. But I think often it is helpful to give patients the diagnosis. It is helpful for the GP.
I agree.
To sort of put an end to it and just say, this is very likely to be myelodysplastic syndrome. The film is abnormal, the counts fit, the phenotype fits, and we can confirm that by showing, a good level of one or more, typically more than 1 mutation would be enough to sort of say this person's got myelodysplastic syndrome. And I would label them as MDS rather than getting too much into the weeds of CCUS or ICUS, which I think is really difficult for non-hematologists to really understand what you're saying.
Yeah, probably is.
So I think that's one reason we would often do it on the peripheral blood. Now I appreciate it's not
so you would actually do it up front. Because we're trying to figure out how we could do this more rationally.
Yeah, I think we've gone almost too much the other way, to be honest. So during COVID, when people were not coming to see it at all, there was a massive spike in peripheral blood myeloid panels. And probably we need to come down, because the worry on the other hand is that you get a mutation and you say, oh, this person's got MDS. You then see the patient and realise that no, something else is going on. And actually they do need a bone marrow biopsy, or they do need a CT, because we're going to miss the fact that they've got something else, and people are So I think it really takes an expert to say that I'm confident that this is MDS and I'm just using the myeloid panel in the blood to confirm my very high level of suspicion, rather than I'm using it as a blanket screening tool to say anyone with this mutation has MDS. Because I've definitely, patients have got into trouble, I think, with that when we've been too reliant on it. So it's difficult. So I think if they're going to have a bone marrow biopsy, just do it on the bone marrow biopsy rather than. But if you're thinking this patient probably isn't going to have one for whatever reason, then I think it's not unreasonable to think whether it would be helpful.
But it is also helpful in a way, because you can see if you have an anemic elderly person, they might actually benefit from EPO and transfusions and things like that. So before you send them back to the GP with nothing.
I think you're right. I mean, I think that makes a big difference. You would manage them the way that you would a low risk MDS patient with
exactly.
anemia, but it's just given you a high level of confidence that this is what's going on. So I think that's nice. Another thing is that it's also nice for the maybe 2/3 that do not have a mutation, because then you can say this is not what's going on. I mean, well, it's a good discussion, because I think, so I want to ask you a question now, because we've been through the different ones. So your hospital director tells you that you need to cut the budget for diagnostics. What would you cut? Always. So I guess I guess, so what's important and what's expensive, I guess, when you get asked those questions by management. So a lot of people probably say, I'll just ditch morphology, but I wouldn't ditch morphology, because I think that it's still really valuable and an essential part of diagnostics.
And of course, you might also find a lymphoma or
absolutely. So, so I think definitely would keep morphology. I think you'd be hard pushed to not keep a karyotype, because again, del5q, p53, all these things you can pick up, and we have been picking up and using that. So I think if something had to go, it probably, or certainly the peripheral blood myeloid panels that I've just been talking about saying that we would do, you could argue that actually we don't really need to be doing them on the peripheral blood. So for us, that probably would save us quite a lot of money, because we do quite a few on the peripheral blood, and then really think about who you're going to do them on when you do a bone marrow biopsy. I think would probably be, so you're almost going back to what we've done for years, in terms of cytogenetics. I think that's probably still the mainstay of diagnosis. And then only in cases where you had a high index of suspicion, but your karyotype had failed or it didn't show anything, then you could sort of selectively do an NGS panel. And NGS panels are becoming cheaper. So we have an in-house one, which just gets bigger and bigger and bigger, because we're constantly adding things in, often more for research purposes. But actually, you don't need that.
How many? You only need these 30, 40 genes, right?
Yeah, exactly. And certainly for clonal hematopoiesis, there's talk of bringing in much smaller panels.
I heard about that. That sounds nice in a way, about 8 genes.
Exactly. Whereas in certain labs where we've got 40, 50, 60, 70 genes, you don't need that. So I think you could restrict that in terms of the number of genes and the expense, and also the patients that you were offering it to. That's what I would do.
Okay, sounds good. So we talked about what we use in the diagnostic situation, but what about follow-up?
We've tried to look at this, and we should probably publish this with getting some other groups involved in that. What impact does a follow-up NGS panel really have? Because often these things are sort of routinely requested.
Exactly.
And you can't, at the moment, most NGS panels, they're not validated for sort of measurable residual disease monitoring. So unlike real-time PCR or certain flow cytometry assays that are validated for MRD monitoring in AML, I suppose we're talking about.
That's AML.
The problem with MDS is obviously you don't have the flow MRD, and you don't have the fusions that often you would do for AML in terms of real-time PCR. So people often will then do an NGS panel thinking, maybe that will be helpful. It's helpful sometimes in terms of clonal evolution, if you're worried that something else is going on. But in terms of, we officially only report mutations that are above 5% on the panel that we've got. Obviously, when we then look at the files, we can then look in more detail and see they've got lower levels of mutations. But it shouldn't really be used to influence patient management at the moment. So I think we need to be very careful. So there isn't an obvious role for follow-up expensive myeloid panels just routinely in patients, I think, outside of a clinical trial setting.
I agree. Yeah. I think this is important.
But I can see why they get done.
There's a lot of wasted on that in a way.
Yeah,
also personnel and time, right?
Absolutely, in terms of resources and reporting, and it all takes time. As much as it seems quick, it's not that quick.
Exactly.
Yeah.
And one thing I think that might be important to also talk about, what about whole genome sequencing?
Yeah.
Does it have a place here? Can it replace what we're doing on our?
Yeah. So I think whole genome sequencing, again, AML often sort of is a step ahead in some ways. It has certainly been. There was a New England Journal paper a couple of years ago looking at adding in whole genome sequencing to your routine pipeline for AML, saying that it was feasible. But obviously, this is big institutes that are used to running these pipelines. Of
course, yeah. I'm thinking ahead a little bit.
Yeah, exactly. So I think there is a big push for whole genome sequencing. Advantages are that you can get your copy number alterations as well as your point mutations, which is great. So you can either use it in a targeted way or in a discovery way as well, so you get far more information. The downsides at the moment are, one, the coverage is not so good. So when we talk about coverage, what we mean is that when you sequence a certain area, the number of reads you have, or sort of the number of times that bit of the genome is sequenced, is far shallower with whole genome sequencing predominantly from an expense perspective. But it's getting cheaper, so that they will be able.
But that also means that you won't find the smaller clones in them, right? Yeah.
Again, when people talk about P53, you can pick up whether it's multi-hit, but you're still only looking at VAFs at 20% and above, maybe a bit lower if you're lucky. So no, you're absolutely right. So the small clones you can't pick up on whole genome sequencing. It's more expensive. The bioinformatic pipelines are really not in place for it to be a quick sort of throughput in a routine lab. That needs more work. But yes, you do get more information in that one test. So I think there is a role for it, and we use it in patients more where the diagnosis is unclear. So not so much. Again, as a discovery tool. And sorry, the other thing that most whole genome sequencing bioinformatic pipelines require is a germline control. Exactly. So you can do tumor only, but most of them require a germline control. And there's a lot of controversy about what you should or shouldn't, or practically you can use as a germline control to show that these are acquired somatic mutations, which is not a problem that you have with targeted panels.
No, of course not. And that takes me actually to germline disorders, who also leads to MDS, because how do you pick up those?
Yeah, so we, I guess you go back in terms of clinical practice, you think about patients, and often we think about them always having to be young, and then I guess certainly new mutations that we've more recently learned about, like DDX41, have shown us what we always kind of should have known, is that this is not the case. You still, even if someone's often maybe would have said in their 20s, 30s, 40s, oh, maybe there's something germline going on, but you can be much older and they still have a germline predisposition. So that's taught us a lot, I think, as adult hematologists, whereas the pediatricians are obviously looking for it. But clearly things that would point you in that direction are a family history or a physical phenotype that might make you think along those lines. But germline predisposition is very important, not only for the individual and for the family screening, which is, I think we found it very difficult in terms of working out what to do with DDX41, and certainly
it's very difficult. I agree,
particularly with regards to the family screening. So which we need sort of more international clarity on really what we should be doing in terms of for the screening. For the patient, obviously, a lot of these, for the patients with MDS, often you typically would have a germline mutation. Often they may then acquire an additional typical somatic mutation. So the management of those patients is somewhat clearer than the family screening. And the other thing I think germline screening is really important to think about is that when you're thinking about transplantation, exactly. So if you've got a family history or any indication that there may be a germline predisposition, you're thinking about sibling donors, or now we're doing a lot more haplos donors, it's a major issue. So not just for the patient, but for family members and for future transplantation. And sorry, back to your original question about how you pick them up. On NGS panels now, most people probably would have incorporated DDX41 specifically. But when you see other mutations that may be more typical for a germline mutation, so things like, I don't know, CBP4 or RUNX or things like that, where if you've got a variant allele frequency that is more typical for a germline mutation, we would then ask for a skin biopsy, culture fibroblasts, and sequence that, and then send them for genetic counselling if we have an indication.
And that is always the first step, right? The genetic counselling. Yeah.
So that's not something we take on at all in our practice as hematologists. That's something that's very special.
So what about whole genome sequencing in that respect? How efficient is it to pick up the germline?
Yeah. So I think personally in our lab, I don't have as much to do with whole genome sequencing, but it's more robust in terms of picking up germline variants for sure.
Yeah, good. So now we have known clone hematopoiesis for 10 years maybe, and we are getting a little bit wiser every day, I guess, because there's so many publications. But what do you think about CHIP, and what do you do if you pick up a mutation that is potentially CHIP in your lab?
Yeah, so I think that the first thing you mentioned about picking up a mutation is really important, because there's a big difference in what the huge sort of population studies, so 200,000 in UK Biobank, other studies in the US, other international collaborations are picking up, and what we pick up in a diagnostics lab is totally different, because anyone who's come to a diagnostics lab in general has a problem. They're not totally healthy. So we pick up very little CHIP. So for you to get a myeloid panel, there is some filtering. When I was saying earlier, we do loads. We're not crazy. We don't do them on absolutely everyone. But still, you generally would have had an abnormal full blood count. So the ones that we then call CHIP are the ones that then their counts then recover, and it was clearly a reactive course, and then you've picked up a mutation, but they've got normal counts. Or the other ones are the ones that come in query MPN.
Yeah.
So I think. But to be honest, it's a handful. Most of this is very much in the research domain when you think about real CHIP. And even when you look at some of the biggest studies, they're not very clear as to whether these patients do have something else going on and what their blood counts really are. So are they
because the information is simply not there.
Hematopoiesis indeterminate potential? Because if you've got by definition, to be CHIP, you have a somatic mutation, more than 2% variant allele frequency in a gene that is known to predispose you to a blood cancer. But some of these patients, and with normal blood count, but so I think it's a very different what we see really in a diagnostics lab compared to what sort of the population-wide studies are demonstrating. So we certainly don't have yet a CHIP clinic as such. And I think it's really about the reason to do it is to sort of have prospective cohorts of patients going forward, not because it's really going to make that much difference to the majority of patients. Remembering that, we talk about blood cancer risk or even cardiovascular risk and overall mortality, but 95% of these patients are going to be with real CHIP are going to be absolutely fine. There's a 1% risk per year, we think, at max, of developing a blood cancer, a higher risk of cardiovascular disease. So I think we need to be really careful about how we run this into routine practice. Research, brilliant. I mean, we should definitely be doing as much research as we can on this, but actually it's hard to talk to patients, I think, as well, about what this really
because you're actually making healthy people sick by telling them they have a mutation.
Exactly. And not much has been published on that. So there's a study of patients in the US looking at whether patients wanted to know about CHIP. But it was a study of women who'd had breast cancer. That's a very, very different cohort of people.
It's very different. It's very different. I mean, after cancer treatment, I think it's very different because, I mean, there's studies also in lymphoma, for example, showing that it actually is associated with a poor prognosis.
Yeah, it absolutely.
At least,
and then we shouldn't really be calling those people CHIP, and it's not of indeterminate potential. They've declared themselves as having potential,
having something. Exactly.
Doesn't make any sense.
You're right.
So I think
it's a good point.
I think potentially more from the cardiovascular side and incorporating more of our cardiovascular colleagues into these discussions or other inflammatory disorders is more valuable than worrying about whether they're going to get AML. Not having said that, obviously, a couple of papers have now been published from the Cambridge group and from Boston, providing scores of how you might assess whether someone's high or low risk. So, incorporating full blood count data, which is really interesting from a diagnostic perspective. So, as well as looking at MCV and RDW, whether there are other factors in your raw full blood count data, there probably are, which can determine whether you're more likely to develop cancer in the future. That AI would be very useful for. So whether you can, before patients, earlier along the pathway, can you detect these patients? Obviously a very good question, but without alarming,
everyone. So if you can identify like a high risk CHIP,
then I think that is worth doing.
Very nice. I think this was I think we came around everything now. I'm very happy. Hope you're happy too.
That was great. I really enjoyed it.
And that the education committee will be happy. So thank you very much for.
No worries. Thank you very much.